Good afternoon, everyone. Dr. Dizon, thank you for that wonderful talk. It was fantastic. So I'm going to talk, and this is actually, I've been asked to do in 25 minutes, which is, it's a semester-long talk. So you'll have to bear with me. But I'm hoping to give you some key principles. I just want to set the expectation. We will not be covering every modality and every single thing, but just to think of some big principles, think of a little bit about how to ask the right questions around these modalities so that when you go to your provider's office, you know what to ask and how to ask it. And also feel comfortable that you can ask it and you should ask them. And if they're not able to answer them, what can you do after that as well? So I think I want to just sort of set that expectation, but hopefully that will do. So we'll talk a little bit about some of the historical perspectives, some terminology. We'll just talk about how people spend money on this, because many people will not tell their providers that they're spending money on this and doing it, but yet it's important to recognize it. We'll talk a little bit about where you can find some of the evidence as patients, and also how you can tell your doctors how they can find the evidence, because they say, oh, we don't know where the evidence is. You can say, well, actually, there are places you can look at the evidence, and you can help me decide as an informed patient. And we'll just go use a case study to illustrate that. So I'm going to do a quick history of medicine. This is sort of how medicine has evolved. If you go back to BC times, quick history of medicine says here, chew this root. You have a provider, you have the patient. And then we moved forward into the Dark Ages. Say that root says heathen, recite this prayer. We moved forward again, says that prayer is superstition, sip this potion. Then with the advent of sort of pharmaceuticals and such, and especially it became popular in the military. A lot of people don't realize the military's role in this. That potion is snake juice, swallow this pill. Then we moved into antibiotic era. As many of you know, we gave antibiotics for everything, including viral infections and such. And he said, take this, so that pill is ineffective, take this antibiotic. And then back, here's that antibiotic is artificial, here, chew this root. So that's where we have come, right? And especially being on this side of Massachusetts, many of you are aware, as you go further west and a little bit north, there's a culture, a countercultural movement that has been very, very popular and has a huge influence. Whether or not actually healthcare providers in the traditional sense have recognized it or not, it has a tremendous influence in the ways in which we make decisions. So, my exposure into this really came from patients. When I was a student and as a resident, we would encounter patients and they would ask questions. So this is a 44-year-old female who had stage 1 non-small cell lung cancer, who really was treated for surgical excision, so everything was told it was cured, right? It was cured. And presented for a routine physical exam. She came in with some mild exertional dyspnea associated with just a little bit of chest comfort. Their family history, there was really nothing contributory, was married, had a previous history of tobacco use, and denied any alcohol or illicit drug use, and tended to eat a lot of fast food. So slightly elevated body mass index of 31, overweight into what we would call class 1 obesity, slightly elevated blood pressure. Really, when we did some labs on this patient, normal white blood cell, hemoglobin, platelet counts, the kidneys look good, there's really no diabetic issues, but really, there were some chronic cystic findings in the chest that were really unchanged. So really, it was unremarkable. They'd done an EKG. We did an EKG. It was normal. Stress test was normal. So our plan was diet and exercise counseling. We tried to, in those days, we would start, again, when we think about a cancer survivor, we begin to re-enter them into sort of, we got to go back to the routine health maintenance, right? So that means, okay, maybe we need medication. That's the way we were taught, right? So let's start something for your blood pressure. Maybe we can help do something to help you lose weight using medication. And the diet and exercise counseling, as we were taught in those days, diet counseling was basically eat less. That's what we told them, and that's it. We checked that box. And then exercise counseling was do more, So we did those. So that's how we were taught. And so the patient's like, well, doc, wait, hold on for a moment. I really want you to consider this one thing. So this patient brings in this magazine and says, how your mind can heal your body, new ways to beat the blues, the link between mental, physical health is happiness in your genes, and such. So it really began to make me think, like, is there something here? Like, how are we thinking about these other modalities? I had never even thought about the word meditation as a healthcare application or as a healthcare sort of treatment option. But then subsequently, later on in my training, a mentor of mine said, well, if you look at the word medication and meditation, it only differs by one letter. So again, to realize that there's some healing potentials, and then we began to sort of think about, what about the other possibilities? The word acupuncture wasn't even in my vocabulary in that day. Massage therapy, I thought that's just something people who had a lot of money do. And chiropractic care, we said, well, that's quackery. Right? That's how we were taught. When we think about all these different sort of treatment modalities that are become a little bit part of our vocabulary today. Now, as you know, we're sort of in a different way of approaching these, especially when we think about pain management or anything that has to do with symptom management. We have to think of non-pharmacologic options. And this is the reason why. This is a recent paper just from last year that has looked at this is a picture of the globe as to how it relates to opiate consumption around the world. And you can see that US and Canada have a much greater proportion of opiate use. We use 30 times more, both countries, than the rest of the world per person of opiate, amount of opiate. So just something to think about. And now, obviously, because this is in 2018, that inflated bubble we're forced to shrink. We have to really do a good job of shrinking this very quickly as we are seeing the unintended consequences. But this does affect the way in which we deliver oncologic care, because this has been a mainstay of symptom management. And now all of a sudden physicians have been forced, fairly or unfairly in some ways, and it's unfair perhaps sometimes to the patients to say, you can't, well, no, we cannot give you any more opiates, even if it is indicated appropriately. So let's now go a little bit through terminology. So the terminology around all these integrated modalities, complementary, I'm going to talk about them. There's been a lot of words, and you're going to hear some of your providers use these words, and they really are, some of them are older terms that we really don't use anymore, but you'll still hear it. Unorthodox, unproven medicine, unconventional, non-conventional. Then we move to traditional medicine. I mean, it was sort of traditional. I'm not sure what tradition means, because tradition in the United States is, what is the tradition? And then you think about what that means. But you'll hear this word. Then you have alternative and complementary. That was the big push. We actually had an institute at the, we still do, but it's gotten renamed, but it was called the National Center for Complementary and Alternative Medicine originally. Then we move to the word integrative, and now that center has been renamed as the National Center for Complementary and Integrative Health. And the reason is because we do think that these are not meant to be used in place of, but really in collaboration with. And that has led to some people using, and we use this obviously in cancer centers all the time, the comprehensive cancer center or the collaborative cancer centers, and that terminology is in integrative approaches as well. So the definition of complementary and alternative medicine and complementary and integrative medicine has really been, and again, you can see this definition is quite fluid. So when people refer to this, you have to ask them, well, what are you talking about? And this is really a group of diverse medical and healthcare interventions, practices, products, or disciplines that are not generally considered a part of conventional medicine. The boundaries between CAM and now we say integrative medicine and conventional medicine, which we sometimes say Western medicine, again, that's a little bit of a interesting, if you talk to a sociologist, and the idea of what is West and East kind of becomes interesting. And allopathic medicine are not absolute. The boundaries are constantly evolving. Interventions such as hospice care, again, and relaxation and breathing techniques at childbirth were once considered unconventional and now are widely accepted. So again, this is a very fluid, and again, today we see that approaches like acupuncture and such are Is it really considered complementary anymore, or is it really just good medicine, ultimately, is what we talk about. So integrative medicine, I think one of the things we want to sort of impress is really combining the best of conventional and evidence-based CAM therapies. We really want to use the evidence to inform or guide clinical care, but it also, as it's sort of been the theme here, is emphasizing patient participation. So when you are going to seek out some of these modalities, that you really are thinking about what is patient participation in maximizing health. It really emphasizes the primacy of the patient-provider relationship and the importance of shared decision-making. And finally, it is emphasizing the contribution of the encounter itself. Excuse me. So we know that many of these approaches, simply just being able to go to the provider and share your story is in and of itself has therapeutic value. And the way that our providers actually listen to us, genuinely listen to us, not listen, but genuinely, authentically listen, actually has an influence on patient outcome. And this is no different for cancer survivors as it is for the general population. And finally, it seeks to optimize an individual's innate healing capacity. So, people use these modalities quite a bit. You know, anywhere between 1/3 to 40% of the population has used some form of integrated modalities. And you know, it may have even slightly increased. Amongst cancer survivors, the prevalence is actually quite great. It's 40 to 60% have used it. And I would venture to guess, how many of you have accessed an integrated modality in the past year? Raise your hand. Yeah, so we're seeing roughly about 1/3 of the group. But again, we can see that the rates are much higher. And why do people use it? Well, amongst cancer survivors, often for wellness, energy, immune function, pain-related symptoms, psychological distress, sleep issues. These are the top common, and typically on these are significantly higher reasons why cancer survivors use it as compared to people who are not cancer survivors. And the rates are increasing. So when we look at rates of yoga and meditation, you can see like it's skyrocketed from 10% of the population. This is now general population, but you can now just sort of extrapolate what is it, because the cancer survivor, again, in some ways, if not, their rates are even higher than the general population. 10% to 15% with yoga classes, participation in yoga. And you think about it today, a gym, if any of you are participating in any gym, or if you participate part of Live Strong, any of these, any good survivorship program likely has to include yoga, or has it as a part of it. I mean, it would be really now odd to not see a yoga component to a comprehensive cancer survivorship program. And even in children, these rates are increasing. So again, we haven't really talked much about childhood cancer survivors, survivors of individuals who had cancer in childhood or adolescence, but also it's increased in there too. People spend a lot of money. I'm willing to bet that many of you who have accessed to these modalities, many of you have probably spent your own dollars on this because, and I'll show you why, because it isn't, well, people don't know how things are covered, and so they'll just spend because it's an opportunity to use. And you can see that people say spend as much probably for these services as they do for MD services and copays combined. That's how much money is being spent when we look at it at a societal level. We're looking at almost $30 billion in the United States. These are 2012 numbers. We're going to have updated numbers from 2017 in this year to understand what has changed. And again, when we look at the totality of healthcare spending, this is mainly discretionary dollars that patients use out of their own pocket. So they're not necessarily utilizing their reimbursed services. People that do have, we're seeing an increased number of visits now. So if we say that in the United States, 50 billion visits were happening to physicians, almost now, $50 billion dollars were spent for out-of-pocket spending towards physician visits. We have now $15 billion spent for complementary provider visits. So that's to see providers. Then there are things that people do without even seeing a provider, right? So if you're buying supplements, those are not necessarily at the provider's office or such. You may be just going on your own and say, oh, I'm going to buy this supplement, this supplement, this supplement, and all of a sudden those costs will add up too. So what are the common approaches that have been used? Obviously, we're going to talk a little bit about herbal and dietary supplements. We've mentioned, again, meditation and yoga practices. We won't really get into other systems of medicine today, but again, these are things like Ayurveda, homeopathy, naturopathy, but those are also things that people will use as well. We see that, all across the age range people are using, but typically we have found that now the older population is using it more. I'd like to think that maybe it was something about that they were in their 20s and 30s and the 60s, and maybe there's that vibe of trying things that was happening in the 60s that is happening now as they're 70 and such. But it's something. It's just something because oftentimes these are patients that also are on multiple pharmacologic agents as well. So you have to keep that in mind as well. And when we look across different race and ethnicity, again, high prevalence of use, but certainly with the reference population being sort of the white population, we do see high rates of, but differences between some of the other ethnic populations as well. So here's how we want to sort of divide up the different domains. We're going to talk about a couple of these just so that you have sort of a flavor of how to think about it. Again, the idea is to set up a framework of thinking about it. Not necessarily, I'm not going to sort of go into specifics of each of the herbs or each of these modalities, just because simply that's, like I said, it's a semester-long course or longer. So dietary supplements, as some of you may or may not be aware, was not a definition that medical professionals came up with. It was actually a definition that was done by Congress. In 1994, the Dietary Supplement Health and Education Act defined dietary supplements as something that contains one or more dietary ingredients, including vitamins, minerals, herbs, botanicals, amino acids, other substances. And it was actually one of the most strongest bipartisan legislations that happened. It was a collaboration of Senator Orrin Hatch from Utah, an ardent Republican, with Senator Tom Harkin of Iowa, an ardent Democrat, and they came together on this topic, and then they basically smashed the FDA single-handedly because they made it look like a food rather than it being a drug. That's basically what was a consequence of this act. So that way they said this is about individual choice, and this is about protecting. Each of them had respective protections. Many of the dietary supplement manufacturers, for example, are based in Utah. So Orrin Hatch was protecting his constituents. Tom Harkin had a personal experience in his own life with dietary supplements and said, this is very important. I don't need anyone telling me I can't do this. I need to be able to do it. So it was this interesting as a teamwork that happened. It made it difficult, though, for the health system at large because it automatically put physicians primarily on the defensive and saying that this is all really not worth anything. It's all placebo. Like you see all these sort of disparaging words that physicians started to use as a consequence of that. And the other biological, some of you practice, there are many, many different types of diets, and the latest fads, you have weight loss, ketogenic, elimination, all these things. And obviously that enters into now cancer survivor lingo today as well. Think about what should be the anti-inflammatory diet I should be on, or what should be the anti-cancer diet. And there are tons of books that are written on these topics. I'm not going to, again, get into this, but the idea to think about, like, what is it that we're really prioritizing here? Are we really prioritizing the quality of our food? Or are we really trying to think about a sustainable lifestyle? Or are we thinking about what might actually is part of our treatment plan? So again, those are things to think about. So this might be somehow how you might be feeling. It's something for the supplement cart. If you go today, you often associate dietary supplements with these sort of hippie stores. You had, they have these sort of bottles set up, and you kind of like, and that may be what. But if you actually go, the majority of the sales today happen in pharmacies. like CVS is one of the biggest retailers of dietary supplements. Rite Aid, Walgreens, if you go to their aisles, you see they have probably 2 to 3 aisles devoted to herbal and dietary supplements. So it is, yes, many people think, oh, I go to my Whole Foods and that section has all those nice smelling soaps and supplements and everything, and that's happening there, but it's really in the common places. And the one thing that they always will tell you, if you go to the pharmacist and say, oh, what do you think? Should I take this? They often will say, we actually did an experiment with our residents, and we had them go in and as sort of educated consumers into these pharmacies. The response of the pharmacist was, talk to your doctor about it, which was ironic, to hear that, because this was, if you begin to think of these pharmacologic substances. Again, this is often how the media portrays this, is that this is like, oh, we're going to do this in replacement of pharmaceutical. And while that might be true for some people, it's not true for the vast majority. Many people are looking to enhance, augment, improve their responses to the pharmacologic agents that they're on or treatment options that they're on. So again, people spend a lot of money on this. If you look at the relative proportions, if we're spending about $50 billion on prescription drugs, we're spending at least a third, if not more, at least a quarter, if not more, on natural products and herbal and dietary supplements. The challenge, again, when we look at the epidemiology, some of the work I had done in my own research was we found that 1 in 5 had used herbal and dietary supplements past year, but 2/3 don't disclose use. And that becomes problematic. Because if you don't tell your provider about it, then it's very hard to understand if there are possible interactions, but also equally important, we always focus on the interactions, is if there are possible benefits. That's the only way that we're going to know, is if we have it. So one of the take-home point number 1 is really talk to your providers about it. If they don't ask, you still tell them about it, because that's only going to lead to better care. And all of our electronic record systems now are set up so that they can actually assess for some of the interactions that might be present. So it's really should be not, I was like, oh, I don't even know where to enter this in the record. No, so what I do in my clinical practice is I actually go through and enter it in as like a medication. So it shows up in the same line as raloxifene or in any of the, any of the medications that you might be taking for your treatment. But you also are taking these as well. It becomes very clear that this is being viewed as a pharmacologically active substance, which it is. The list of commonly used ones constantly changes, and again, we look to the national surveys to help guide and you can tell it actually follows the evidence and the media. So if you go to 2002, the most commonly prescribed supplement was echinacea. It was the one that people bought a ton of. Some of you may have used it. And then in around 2005, there was a landmark New England Journal of Medicine study that showed that echinacea didn't do anything for the common cold. So you can see that by 2007, it went down from 40% to 15% in less than 5 years. Now the challenge with that study, and I'm just going to give you is that if you're not really know the details of the study, it can change market patterns dramatically. But in that study, it turns out the faults of the study, and this was published in the most eminent journal in the world, was that they used a different species of echinacea and at the wrong dose. So it was already powered to set up in a way that it was going to fail. But people didn't see that fine print, and they said echinacea. It turns out there are 3 big species of echinacea, and they don't all work the same. And they're not all equivalent. So again, some of the things to think about are just, it's not to say that it may or may not, but the data is never definitive. It is always going to be a constant dialogue and interaction of like, where does the thing stand today? What are the pros and cons? And what am I comparing this against? What is my alternative option? What's the opportunity cost here? And that's some of the things to think about. I mentioned that one of the reasons around this DSHEA Act that was so important was that it treated these products like foods, which is not true in other countries. So like for example, in Germany, you have to be a physician to prescribe herbal and dietary supplements, whereas here you can just buy it off the shelf. Labels must make structure function claims, but they can't say that it treats and prevents disease. Well, this for a consumer becomes very confusing. So if you look at a product like fish oil, right, you see it off there. If you look at what does it say, if you go to it, it will say promotes mood support and heart health. But they can't say that it's used to treat hypertriglyceridemia or in the treatment of depression. But for a consumer, it may sound kind of wishy-washy in between. And there is no legal or regulatory definition of standardization. That makes it difficult. It actually took us about 10 years to come up with actually good manufacturing practices that large manufacturers of supplements agreed upon. So again, there's a lot of politics here, and I just bring that up because as individuals, as people who influence your policymakers, these are important things to think about, and actually can help guide how we how we actually ensure that proper controls are in place to have good quality products, to have consistency, and it applies both to domestic and foreign companies. You know, those are the important things. Now, here are some of the things you can look for. Again, this is not meant to say that supplements that don't have these labels are bad, but these people who have subjected themselves to these labeling means that they have undergone some sort of third-party verification. So this is an example. USP, you may have seen these stickers or labels on some of the supplements. National Sanitary Foundation and Consumer Labs. So these are, and Consumer Lab is actually an interesting one because you can actually, they actually independently test and they declare this product is bad and good. And they use their own methodology, so it's truly a third-party verification system. But the challenge is it doesn't cover all products. So it does cover the common ones, but it won't cover everything. And so again, there is limitation, but does give a place to start, both as a consumer and something you can tell your provider as well. Can you look up, you know, can you tell me, Consumer Labs is available as an individual subscription sort of platform for individuals to look at. Mind-body practices, we've talked a little bit about it today, so I want to just highlight a couple of things there. You know, mind-body medicines is really about, you know, practices that evoke powerful ways in which their emotional, mental, social, spiritual factors, they can directly affect health. It's about understanding someone's capacity for self-knowledge and self-care, and emphasize these techniques grounded in this approach. So when you treat patients with mind-body medicine, we found there's a whole swath of literature now, and I won't you know, go through it in detail, but it reduces frequency of symptoms and increases health-promoting lifestyles, and it continues to increase in popularity, as I've mentioned. There are many famous, and Massachusetts has been sort of the beneficiary of having very famous programs that have originated in here. Some of you may be familiar. I'm going to briefly describe our program, the SMART Stress Management Resiliency Training Program, which was mentioned earlier today. Originally, really, Dr. Herbert Benson, he was the one who talked about the relaxation response, and that's a famous book that some of you may have read that came out in the 70s. John Kabat-Zinn, based in Worcester at UMass Medical Center, developed the mindfulness-based stress reduction. There are many derivatives of that model as well. There are other models as well. And what we've found that when we look at these programs, they're really built on a three-tiered process. They're techniques that elicit a physiologic change. There's also a stress awareness piece, and then there's really about promoting social connected and healthy lifestyle behaviors. And our model, as was mentioned, is an 8-week multimodal program that incorporates elements of modern psychotherapy with wisdom traditions through mind-body practices. So what does this help? It's really about really multiple domains and how these are really healthcare provider-led rituals, but it's really about empowering the patient to take care of themselves. Just really quickly, I want to talk about some of the manual therapies. Chiropractic care and massage therapy have been shown, and in fact, they are now, I just showed this whole thing, it is actually first-line recommendation for non-pharmacologic approach to low back pain, as declared by the American College of Physicians last year. This was really blew away a lot of people because for them to say this was really quite extraordinary. Acupuncture, you know, this is where somebody, you know, this is really, again, based on systems that arise from traditional Chinese medicine and Japanese and Korean traditions, but has really now had a broad application, especially in cancer treatment, and now is being examined in cancer survivorship. And here's an example of study insomnia being done. This is literally hot off the press, just from a little over a month ago, looking at an evidence-based modality, CBTI, cognitive behavioral therapy for insomnia, with acupuncture. And they found that while CBTI still is better than acupuncture, they were both clinically meaningful results. They both had clinically meaningful results, if that makes sense. So both are options. Now the challenge is finding a licensed provider. And again, chiropractic care is easy. Every state in the United States has a board, it has its own board regulation. Massage therapy is better, and acupuncture is almost now is just as good as well. The challenge is there's variations of coverage, and this just shows, this table is just demonstrating that there's, looking at low back pain, for which we had these great recommendations, you can't really access them because many of, especially acupuncture, you have to pay out of pocket. Now, in the state of Massachusetts, it's very much payer dependent, and Medicare, unfortunately, does not cover acupuncture, except right now they've invited a public dialogue into looking at its coverage. So, you can go to the website and see if this is, it's really inviting the public commentary on it. So where do you, finally wrapping up in my last minute, resources, websites. So these are resources you can tell your providers to use. Consumer Labs, I mentioned, Natural Standard, Micromedics, these all have approaches, ways of, these are more provider-centered websites. But then also, these are both patient-centered and provider-centered. So the National Center for Complementary Integrative Health, really wonderful patient information on it. National Cancer Institute, in their Office of Complementary, they still have called it the Office of Complementary and Alternative Medicine. Have it. Mayo Clinic was mentioned earlier, Memorial Sloan Kettering Cancer Center. They really good have patient education sites. And then I'm based both at the Brigham and at MGH, and again in the Boston area, we have a wealth of individuals who, like myself, who are able to address patient concerns around complementary and integrated modalities, and some that are also in the cancer specific. So the Osher Center for Integrative Medicine at the Brigham, the Dana-Farber Cancer Center, ZACM, and then our institute, the Benson-Henry Institute for Mind-Body Medicine. We do run a mind-body program for cancer survivors based on the SMART program that was talked about earlier today. And again, really are trying to balance quality, safety, and efficacy. So I think with that, really this is about the rules that integrative medicine must follow. It's care based on continuous healing relationships, a customization based on patient needs and values. You have to be the source of control. You want to find providers that allow you to be the source of control, but there's shared knowledge and free flow of information, and it's a really evidence-based or evidence-guided decision-making process. So don't be afraid. You might have that curmudgeon doctor that says, you've been fooling around with alternative medicines, haven't you? And any questions? And then those of you interested, there are some pamphlets out there with all our contact information, so don't feel free, like this is your only chance to ask questions, but you can feel free to ask afterwards. So thank you. Yeah. So we'll take a couple questions. I'm going to go in the back. Yeah.
Hi. Most of the alternative treatments that I've dealt with, besides things like the meditation and yoga, have been related to dietary supplements. And I have to admit, most of the ones that I'm taking now were actually recommended by my oncologist.
Great.
Now, what else do you think might be the contribution with the fact that there's so much information available from all these websites about these medical supplements? Which ones seem to have clinical results? Which ones don't seem to have clinical results? I mean, how much do you think that you mentioned that people in the 60s and 70s willing to try alternate things?
Yeah.
How much of that is more people are willing to go look up information on websites
Well,
and find out information
absolutely.
from themselves based upon a verbal recommendation from a doctor?
Yes. So I think more physicians are now becoming more comfortable with this because the public has forced it, forced the conversation. It is no longer this sort of like you go somewhere to see somebody to talk about integrated modalities. They're available in most academic medical centers or most comprehensive cancer centers do often employ individuals who are skilled at having these types of dialogues. So I think that's one piece of it. And yes, information is more free-flowing. It used to be guardedly secret, you only could trust your provider says, oh, and that person said that this is the evidence base. But you can actually make an independent judgment, like, is this really the evidence base? And I think that's a changing thing. Yes, one question.
You had mentioned
I did not mention medical marijuana because that is another semester-long conversation. It is, and it is obviously a huge, there are very few providers, I can say confidently, in our state of Massachusetts that actually have the ability to have a very informed dialogue with patients around this. And so, unfortunately, currently, as it stands, most physicians, there are rare exceptions, are in the practice of simply certifying someone. You pay them to get certified, and then that's about it. But there is a.
Are there any studies that you know?
Well, medical marijuana, the challenge has been it was restricted. So studies have been difficult. So we rely upon our European and Canadian colleagues currently. All of that is in real time, right now as we speak, is being, I think it was even on the news, people are trying to figure out how to lift these restrictions to promote more research in this. Great, okay, thank you.